An idea of our audience, over half the people on the call are from a state health department, about 25% from local health departments. So this is sort of our target audience. We really want to, over 75% of the people are out in the field, and another probably 5 or 10% are at local organizations, as well as our colleagues at the Centers for Disease Control. So I think we are meeting our audience. And just to give us an idea of where you are in the PrEP process, if you could let us know whether if you work in a state or local health department or a program that's doing PrEP, are you currently providing PrEP, or do you plan to do it in the next 12 months? You're not planning to provide it, or this doesn't really apply to you? And let's kind of get a feel for our audience as far as, you know, where you are in the PrEP process. So we'll check the results. So this is highly encouraging. Almost 60% of you say you're currently providing PrEP, with another almost 20% saying that you hope to provide it in the next 12 months. So of all our health departments that we have on here, we have over 70% are indicating that they either are or are going to be planning to provide PrEP in the next 12 months, which is highly encouraging. So a couple of housekeeping things. We have all the phones muted. We will be taking questions after each speaker for about 5 minutes, but we can still, and so if you have a question, if you could use that chat function on the lower left hand of your screen, send us a question, and then we will ask the speakers those questions for about 5 minutes, and then if we don't have enough time, we'll still record those questions and ask them at the end of the session, where we should have 15 or 20 minutes left for questions and discussion. So I think, you know, with this many people on, this is probably the best way to do this. We have over 50 people on the call right now. Again, if you have any questions or comments, you know, use the chat function. Our agenda, we're probably running about 5 minutes late, but we're good for time. I'm just doing the intro, and then Bill Smith is going to give us, from NCSD, is going to give us some comments and perspectives about PrEP, and then we're going to hear from Rhode Island, Mississippi, New Mexico, Los Angeles, and then have time for questions and discussion. So let me turn it over to Bill Smith, the Executive Director of NCSD, to give us a little bit of perspective on where NCSD is with PrEP. So, Bill?
Thank you, Charlie, and hello, everyone, and happy afternoon. I hope you all had a great Thanksgiving. Let me just do a few thanks first. First, thanks to the great lineup of presenters today. I'm really looking forward to hearing, as I know many of you are, about examples from the field on how things are going related to pre-exposure prophylaxis. Huge also thanks to Charlie and to Dana on NCSD's Technical Assistance and Health Equity Promotion team for pulling together this and all of our It's Your Calls. We know that they're important in terms of sharing information among our members. And then finally, thanks to all of you who are on the call today for joining. This is a critically important topic for us. I hope that you have seen over the last several years NCSD's leadership in advancing best practices related to PrEP. And we believe it's critically important that STD programs play a really quite dominant role in PrEP, and I'll say a little bit why. But we also believe this is a tremendous opportunity for us to be working with our colleagues in HIV programs and in AIDS service organizations and community-based organizations across the country to end the HIV epidemic. And as many of you know, for the first time, we really do have the tools to end the HIV epidemic. And perhaps first and foremost among them is ensuring that positive people are on antiretroviral therapy, and that for those at risk, we have them on pre-exposure prophylaxis. If you didn't see last week, the MMWR on the estimated number of people in the U.S. who should be on pre-exposure prophylaxis, it's just over 1.2 million. And the data is pretty compelling. It's 1 in 4 people who are men who have sex with men, almost 500,000 men, or about 25% of the estimated MSM population, should be on PrEP. Intravenous drug users at about 18.5%. And not to be overlooked, although I think sometimes it does happen, 624,000 heterosexual people are estimated to be in risk categories and eligible for PrEP. So we have a lot of work to do, and I think one of the things that's most important for us in STD programs, whether we are really looking at our surveillance data to understand how we use surveillance to inform our actions, whether we're running clinical service delivery and figuring out how we directly deliver PrEP or have really strong and collaborative partnerships for referral for PrEP. The need for PrEP is showing up in our STD programs every day. It's in our surveillance data. It's in our positive CT and GC data, particularly our rectal data. And it's what we experience in clinic and service delivery every day. These people are showing up in our programs, and STD programs can play a vital role in ending the HIV epidemic by really focusing on how we are properly prescribing PrEP. And we believe that's true for all staff who are working in health departments. Again, whether you're an epidemiologist or you're a DIS or you're actually a clinician or some other healthcare provider staff working within a clinic, we can make a huge difference here in ending AIDS. So finally, let me just say that I'm really thrilled for the presenters that are talking today. NCSD represents health departments across the country, and one of the things that's always amazing about that role is that innovation really does come from the ground. It comes from our state and local health departments who are trying, in spite of politics, in spite of resources, and in spite of a whole bunch of other things, and really making sure that we are doing our best to promote sexual health and to prevent STDs, including HIV. So I'm really thrilled to hear about the innovation coming from the ground today. And please know going forward you will have the support of NCSD on our technical assistance and leadership and the vital role of STD programs in the role of PrEP. So thanks for everyone for being on today, and looking forward to this call. Back to you, Charlie.
Bill. Okay, great. Thanks, Bill. And I think those of you who were at the NCSD annual meeting in Savannah a couple of weeks ago, we had several sessions on PrEP, and we heard from people from Georgia and San Francisco and other places. And I think this webinar today will give us a chance to hear from some new voices. And I think there's a lot of innovative stuff going on, and I think we can really learn from each other. So without further ado, I'm going to turn it over to Phil Chan in Rhode Island and talk about Rhode Island's experience. So, Philip? Phil, can you hear me?
Hi, I can. Can you hear me?
Okay. Yeah, we can hear you now. And you can either advance your slides or I can advance them. So you can go ahead and start, Phil. Phil, are you still there?
Hi, can you hear me?
Yeah, we can hear you. Go ahead.
Okay, sorry about that. So good morning. My name's Phil Chan. I'm the director of the STD clinic here in Rhode Island, and I'm happy to sort of talk about our experiences here about PrEP in Providence. So our STD clinic was started actually in 2012. It's actually based at one of the community hospitals. It's a partnership with the Rhode Island Department of Health, where I also serve as consultant medical director of the Office for HIV and STDs there. So we started an implementation program in 2013 at our STD clinic. Our STD clinic is largely focused on gay, bisexual, and other men who have sex with men. And so about 30% of our overall clinic population is MSM. We aim to test about a couple thousand people per year. About 70% of our overall patient population are men, with the other quarter women. In 2013, when PrEP had been out for about a year, we decided to do a PrEP implementation program actually at our clinic. What we decided to do was to start educating all MSM who came through the door about PrEP. So the first important point that we started to do actually was that regardless of risk factors, we started to educate MSM about PrEP. So this decision was made because we noticed that there was such a low level of knowledge and awareness about PrEP in the community, and we decided just to help disseminate that by educating all MSM regardless of reported risk factors. The other thing that we did is that we have a campaign that's sort of the face of our STD clinic here in Rhode Island. It's called Do It Right. You can see the RI is highlighted for Rhode Island. And as part of that campaign, we also included pre-exposure prophylaxis and have been heavily promoting that through social media, through different outlets, through community events, etc. So our protocol for when someone first comes in, and I kind of wanted to talk about this, was when a gentleman first presents for STD testing, is we have a one-page intake form that everyone fills out. It has sort of the classic demographics and risk behaviors that the CDC and our local state department asks for. It asks about different sexual behaviors, who your sexual partners are, do you use drugs, etc. After the person completes that, they go on to do the normal HIV STD screening panel. They meet with one of our HIV counselors. These range from a nurse level trained to people that have a bachelor's or a master's degree trained in HIV testing. For people, again, for people that are identified as MSM, they then undergo a couple-minute PrEP education and counseling session. So again, we sort of integrated this session within the context of the normal busy flow. I do think that in general our STD clinic is understaffed, as I'm sure many places are throughout the rest of the country. And it was really, the goal is to do an efficient as possible as well as effective program session where we could educate people about PrEP. We have a one-page sheet that I'm more than happy to share with people that basically summarizes from the CDC the benefits as well as potential concerns about using PrEP that we go over with people. Again, the aim of about this is for 2 or 3 minutes. All counselors in our clinic are trained to do this and do this for the patients. And for people that are interested, they make an appointment with myself for PrEP. And so today we've prescribed about 130 people PrEP. The majority of those are MSM. About 10% are women. About those 10% tend to be women who are in serodiscordant relationships. And then I see these people every 3 months. Our site's a little bit unique in that the STD clinic here in Rhode Island is actually based at the largest and almost the only HIV center here in Rhode Island. And this is where we also have our on-site PrEP program. So it's all closely integrated between STD care, the PrEP program, as well as HIV care. For the next slide, if we could advance it one slide. One thing that we did for people, so out of all the guys that are coming through, we do ask them if they're interested in PrEP. Again, if they are interested, they meet with me. We did do an evaluation and monitoring program where for people who were not interested in PrEP, we asked them why. And I thought I would just share this data because it does provide some unique insights. We are in the process of writing this up. So for the first 234 gay and bisexual men who presented to our clinic that were educated, next slide. We were able to educate, well, all of them were educated. 56% of those initial 234 did cite some interest in PrEP. Again, all these, we have, our STD clinic has an extremely high prevalence of HIV and other STDs. So our seroprevalence among MSM at our STD clinic, which I forgot to mention, is 2.2%. And out of all MSM that walk through the door, there's about a 15 to 18% seroprevalence of other STDs. So definitely syphilis, gonorrhea, chlamydia. For the 44% that were uninterested, the number one reason was that they thought that they were at low risk. So 44%, and then you can see a smattering of other concerns there, ranging from side effects to insurance. Next slide, please. Out of those that were interested, we did not schedule an appointment that day. For some of them we did, but the majority of our protocol said that if you were interested, please provide your phone number or email, and we will call you for contact. Out of the people that were interested, 29%, so about half of the people that initially expressed interest were successfully contacted by phone or email. Next slide, please. Out of those that were contacted, the majority of them actually went on to schedule an appointment. For those that were contacted that had initially said that they were interested, a number did not follow up about PrEP, and that includes because they think that they were low risk. They wanted to think about it more. Again, they were concerned about side effects or insurance. Next slide, please. So the vast majority of those that scheduled an appointment made their appointment. And then the last slide shows that only 11% of those initial 234 actually took up PrEP. So again, this is sort of a work in progress for us. We don't do any other intervention other than go over this one-page sheet and then offer to make a PrEP appointment. But I thought that this would be interesting to the group to show where some of at least the barriers that we ran into just talking to people about PrEP. We have noticed that some of these people just needed to think about it more before they actually were prescribed PrEP. So we sometimes do see a delay from when we educate people to when they take up PrEP. I think overall, though, our PrEP program has been pretty successful. Out of those 130 people that I mentioned we have on PrEP, there was one seroconversion among a young African-American gentleman. I do believe I probably missed acute infection when he first presented for PrEP. So in accordance with CDC guidelines, I do not check a viral load on everyone that presents for PrEP initiation. The biggest reason for that is because insurance has kicked it back to me and people have had to pay out of pocket. So I'm very careful about that. This gentleman did not have any signs or symptoms of acute HIV when I first started PrEP, and he had a negative antibody test on the day of initiation. But at his 3-month test, he did convert to HIV positive and is subsequently my patient in care and on medications. But I have a sneaking suspicion in him I may have missed acute HIV. Some other interesting anecdotal evidence. There's one gentleman that missed his PrEP appointment and then later in the year became HIV positive and entered care in our clinic. And then there's another gentleman that tested positive on the day I was going to start PrEP. So I think overall here at our clinic we're definitely reaching the high-risk group. We have had success getting some people on, but as shown by this slide, we definitely need to do a better job promoting PrEP and talking about risk behaviors with some of these gentlemen. So I'm more than happy to answer any questions, or we can wait till the end. Oops, one last slide. So out of everyone we talked to about PrEP, out of the 234 MSM, these are the reasons why they said they would have any concern about PrEP. So a lot of them, 3/4 of them, and this is regardless of their interest in PrEP or not. You can see that the majority of reason by far was just a concern for side effects. I think this makes sense. Again, a lot of the people that were looking to prescribe PrEP are young, otherwise healthy gay men without a whole lot of medical problems. And then another smattering of reasons ranging from insurance, financial reasons, over half the people, to having to take a daily medication, interaction with drugs or alcohol, other medications, stigma, as well as other. So again, more than happy to answer any questions and go from there. These were just some of the demographics that we had about PrEP at our program. Again, about 100 people. To date, we have about 130 people who have been prescribed to. In July, it was about 100. About 91%, as I mentioned, are PrEP. Next slide. And as I mentioned, one seroconversion, one missed appointment, and one person who tested positive. We've been really super lucky in Rhode Island in the fact that we're a Medicaid expansion state, so the vast majority of our population actually has insurance. So the insurance issue, at least from our standpoint, has not been a problem. There have been a subset of people that have been uninsured or underinsured. We've been able to work with our local medication assistance programs to get people on PrEP and to cover the cost of medical providers.
Okay, great. Well, thanks, Phil. We're going to we'll take questions in a second. So, Stephen, you're going to ask the questions. While we're getting ready for the questions, just a couple things. Any of the tools that the speakers talk about, we'll have them send them to us, and then you can email me, and my email will be in the, later on. You can email me, and we'll send you out the tools that we talk about, as well as we'll have contact information for all the speakers. So if you have additional questions or you need some technical assistance, I'm sure our speakers will be happy to talk to people. So, Stephen, any questions for Philip? I know a couple questions that I see is one is, are you using a fourth-generation HIV test when screening for PrEP?
It's a great question. So we're still actually using a third-generation serum antibody test. We're in the process of switching over this month to the fourth generation. So great question. So not quite yet.
Okay. What's the demographic breakdown of those who choose to follow through with PrEP? Age, race, socioeconomic status, et cetera. Any data on that?
Yeah, so good question. So most of the people on PrEP, so Rhode Island, it sort of reflects the demographics of our local state. So we have a pretty high Hispanic Latino population in Rhode Island, so about 20%-ish are identify as Hispanic Latino, about 10 to 15% of African American, and the rest are white. And again, in terms of talking about MSM, they range all the way from 18 to 19, all the way up to, I have one gentleman who's 63 and on PrEP. And I get a little hesitant in the older generation for prescribing PrEP, just because some of these people have a number of comorbidities. But I have definitely prescribed it to a couple individuals who are over 60 years of age, and that's sort of where I top out.
Okay, one or two more questions, and then we're going to move on. But then everybody who's asked questions, we will be able to get to those questions at the end. So another question is, any idea of the STD rates on PrEP patients?
Yeah, so great question. So we have a really high rate of STDs among the PrEP patients. So I'm going to say probably 25%. So the other thing that we routinely do is extragenital screening, which I certainly encourage people to do if they're not doing it already. But we did a pilot project where we switched over to extragenital screening about a year and a half ago, and we found that we were missing about 70% of gonorrhea and chlamydia infections among MSM. So everyone gets screened at least 6 months, if not 3 months, depending on the number of partners, but about 25% overall.
Okay, and last question for now is, what's the ballpark price range for PrEP medication for the average patient?
So the out-of-pocket, so I've learned a lot about insurance this last year having to deal with this. So in Rhode Island we have 4 major insurers. We have Blue Cross Blue Shield, United Health, Medicaid, and another public-oriented system. All of them we have found have covered PrEP, so we have not had a problem. A couple of them occasionally require prior auth, so we have someone in our clinic that's their only job. But a lot of the companies are dropping their prior auth requirements, and Medicaid has been especially great about just covering it. Gilead, we do have a copay card from Gilead, so I encourage you, if anyone needs more information about this, but Gilead Sciences does provide copay cards which cover the cost of the copay to the patient, which is fantastic. So if you have, if someone has a $50 all the way up to several $100, Gilead will waive the copay for that medication. It's a fantastic program. These cards are available through the reps, and it really leads to almost zero out-of-pocket costs for our patients in terms of medication expenses. The toughest thing that we've had trouble covering in some patients are actually the cost of providing the medical care. So cost of seeing the medical provider, cost of the labs. Patients will occasionally get bills for that because they haven't met their deductible, but we're working with the insurance companies to try to address this.
Okay, great. So again, hopefully we'll have time at the end for those of you who have had additional questions for Philip. We'll hopefully be able to cover those at the end. So moving right along, and I think what's exciting is that not only the large jurisdictions, but some of the smaller, what people think of less lowerly funded project areas have also been successful in implementing PrEP. So let's hear from Brian King to tell us about PrEP in Mississippi. Brian? Brian, can you hear me?
Can you hear me? Can you
hear
me?
Now we can hear you. Great. Thank you.
Okay, great. Yes, and thank you for prefacing that. We are in our infancy stages of working and providing PrEP, and this actually, in the January of 2015, the Mississippi State Department of Health actually established the nation's first PrEP call center for individuals. The CDC had established one for providers, and through very low funding grassroots efforts, we thought, how can we go ahead and start working with PrEP? And as a result of that, we established a PrEP call center, and the telephone number is 844-YES-PrEP. If you don't mind, move on to the next slide.
Sure.
Okay. So we established this call center, and our main goal was to educate individuals about PrEP, determine their risk factors, and then also link them to a prescribing provider. We also are a state where we did not have Medicaid expansion, and of course that made it much more difficult, but now Medicaid is now covering PrEP in the state of Mississippi, and I'll discuss that a little bit further as we go along. So the first full month of January 2015, we were fully operational. We've been working in collaboration with the American Sexual Health Association, and 100% of the callers were educated either about PrEP or PEP, and this is the first 6 months of the year. The reporting periods from January until June the 30th of 2015. We had 64 individuals to call the PrEP Center. And as I mentioned, this was truly a grassroots campaign, me speaking, essentially being the only person speaking about this at any public forum I would have the opportunity to, working with our DIS, working through our medical monitoring project, any way I could possibly get the word out to engage people to call the PrEP call center. I did. And out of the 64, we had 52 of those individuals that were interested in receiving additional information regarding the PrEP, and 95% of those who called chose to have an assessment for PrEP and PEP eligibility. And I'll go into the demographics of it. 79% of the individuals who called were male and 20% were female. And also 79% of those were aged 25 to 49, and aged 18 to 24 were 21%. Now, we do have a clinic that the Mississippi State Department of Health works at. We have our own STD HIV clinic, and we have an LGBT clinic that we're closely affiliated with that is one of our prescribing providers that we do refer some directly to. If we could go to the next slide, that would be great. So some demographics about those who called the PrEP call center: 58% were gay or lesbian, 26% were heterosexual, as you can see, 11% were bisexual, and 5% chose not to disclose their sexual identity. And we wanted to get as much demographical data as we could without scaring the person or asking them too many questions that they lost interest in calling and following through with the prescribing provider. We heavily depend on the providers, the 4 providers that we have in Mississippi, one to cover the coastal region, one to cover the upper southern region of Mississippi, and one to cover the central region of Mississippi where our highest prevalence of HIV is. And then we have a clinic in Memphis that helps us cover those people in northern Mississippi. And, we did have difficulty in getting providers to assist us and that were willing to prescribe PrEP. They felt it was going to be burdensome to them. And actually that has not been the case. The forms to complete are not very difficult. If we go to the next slide, I know this is a little bit difficult to see, and we do not, just say that PrEP is for MSM populations, even though that we know that 25% of that population should actually be on PrEP. Anybody that's at high risk for HIV transmission, then we would like to encourage them. But we do have an MSM risk stratification tool that we use to sort of screen people. And if you score above 10 on the scale, it indicates that you're at highest risk for HIV. And then also at our STD HIV clinic, those individuals that have extragenital testing and let's just say are positive for rectal gonorrhea and or MSM, we definitely want to get them into a prescribing provider. And fortunately, the LGBT clinic is just a block down the road that we can refer them to. They do not get prescribed PrEP the exact same day that they go to the appointment because we want to get a baseline HIV test, and we also want to get a creatinine. And one thing that we've been able to do to help offset the cost, and we do not charge the patient for, is the creatinine. We're able to run that at our public health lab for $2.15. If we could go to the next slide. So in our efforts to really promote and keep interest in the call center, we have got some additional funding. We leveraged through our federal partners, and we have got 5,000 PrEP pocket-sized insert cards that we put into Safer Sex kits. There's about 10,000 Safer Sex kits that we're distributing throughout the state of Mississippi. And then we also use postcards and posters that we put in our STD clinics and in our health departments to encourage people to call the PrEP call center. Media campaigns, and when I was telling you we had a grassroots budget, we are just now able to get money to actually advertise, and so we're expecting further media campaigns will begin this December. And I continue to work through the medical monitoring project and our disease intervention specialists, especially for those people that are at high risk or they've been named as a partner, possibly to, or they're in a serodiscordant relationship. I take any and every opportunity that I can to discuss at public forums. And why I'm telling you this is because, this doesn't cost a lot. It's just a little bit of your time to travel. But it's one way we can, also use PrEP as another arsenal in our tool to prevent HIV infection. So again, any of those individuals that are at highest risk, that are HIV negative or possibly in a serodiscordant relationship, we want them to call the PrEP call center. We do make, in some cases, direct referrals for those individuals that come through our STD HIV clinic just because of the high rate of HIV that we see in that one clinic, which hovers around 6 to 7%. And we also have about 20 to 25% of additional STD rates in those individuals. So we also use our community gatekeepers. Challenges and barriers. One is with the call center, it's unknown if individuals actually follow up with the providers. At our LGBT center, we are actually able to quantify that. We can make the direct referral, and then we already have 100 people that are on PrEP at this time at that one clinic. One of the problems, though, that we do see is that in recent months we've scheduled 40 people to go see the provider. 30 actually only made an appointment, and actually only one person showed up for their to see the provider. Costs associated with the medications and labs, we do depend on Gilead's drug assistance program, and now Medicaid is covering PrEP in the state of Mississippi. We do have a problem with adherence to taking the medication as prescribed, and we do not have any state monies that are allocated to help offset the cost of PrEP. Another barrier that we face in Mississippi is definitely stigma. I can't emphasize that enough, and that's pretty much a direct correlation between the number of people that we referred to the LGBT clinic, and only 1 out of the 40 actually showed up in this situation. Thank you. Again, we have 4 providers across the state of Mississippi and Tennessee, and these are for Mississippi residents. We require at least a rapid HIV negative test prior to beginning the PrEP, and we do the risk determination scale. We do ensure that a creatinine is obtained, and as I mentioned, $2.15 if sent to our public health lab, and all the providers that are willing to prescribe PrEP do use our public health lab and are willing to assist patients in filling out any of the drug assistance forms. And of course, we want routine HIV testing every 3 months or so. And we do have a family planning waiver in Mississippi where now anybody aged 15 to 44 without sterilization can get up to 4 visits per year. And in this family planning waiver, PrEP can also be prescribed. Again, the number for the Mississippi PrEP Call Center is 844-YES-PrEP, and as I mentioned, it is in collaboration with the American Sexual Health Association. I'm pretty sure you guys are all aware of them, and my contact information is on the screen as we speak.
So thanks, Brian. Again, if anybody wants a copy of this tool or anything else, email me at the end, and,
Yes.
and we'll get it to you. So if you have any questions for Brian, if you could just put them in the chat, and we'll take a couple minutes for questions. If not, we'll move on. So I'll wait a minute to see if anybody has any questions. So while we're waiting, how do you think we can address stigma? I mean,
Stigma is one of those things. We brought in focus groups from all over the state to see how we can address it, and we are not making any headway on that. I'll be honest with you. We definitely rely on community gatekeepers, house mothers, house fathers, to help reach the young African American MSM population in the state of Mississippi. They are disproportionately affected by HIV in our state. Severely disproportionately affected. And that's one thing that we continue to struggle with and overcome that barrier.
Okay. How are PrEP providers identified, or how are providers identified or educated about PrEP?
We actually have a consultant, Dr. Leandra Mina, with the Infectious Disease Department at the University of Mississippi Medical Center. He has been one that has been willing to go and talk to the providers, answer any questions, go through protocols for establishing PrEP. He's been great to serve as a resource to anyone, even anybody that might call and say, look, I know we're not with the call center or anything like that, but we want to prescribe PrEP, and he's willing to take their call and tell them what they need to do. So he serves as our resource in Mississippi.
What's the rate of clients that are in PrEP and follow up with a regular checkup?
What's the rate of clients that are in PrEP and follow up with a regular checkup?
Right.
As I mentioned, right now we have about 100 people that are on PrEP, and we pretty much have sustained that rate so far. Lately, as I mentioned, we have been having problems getting people in to see a provider, and the unfortunate part is we don't know the reason why, because they do not follow back up with us, or they might go to another clinic or might go to another health department. So we're not really able to ascertain that data as to why they do not come back.
Okay. And 2 last questions. What are the hours for the call center,
yeah.
and who do you have answering the phones?
Yes, we have trained agents that work with the American Sexual Health Association. It is open Monday through Friday from 7 a.m. to 6 p.m. Central Standard Time. They do have the ability to leave a voicemail, and a lot of people do call after hours, and the agents do call them back the next day or return their call as soon as they possibly can. And we have not had so far any complaints other than the fact that when we initially started, the lack of providers representing regions in Mississippi.
So did ASHA come and train your staff there, or is it the call center somewhere else?
They actually train their staff. They actually employ the staff, and they go through the training through the American Sexual Health Association.
Okay.
They have over 30 years of call center experience, and as we know, they have over 100 years of sexual health experience. So they're more than qualified. There was a script, a very detailed script, that Dr. Mina and I and other people reviewed prior to approving them to use it, and it's pretty comprehensive, and it gives great information.
Okay, great. Well, thanks, Brian. Again, hopefully we'll have, if anybody has questions, we'll have some time at the end. So I'm next going to turn it over to Andrew Gans, who's going to talk about PrEP in New Mexico. And Andrew, you can either advance your own slides or I'll do it.
Great, thanks. If you go ahead, that would be great. Thank you, everyone. First of all, thank you, Charlie. Thank you, NCSD, for inviting me to engage in this discussion. I want to actually talk a little bit differently, which is some of the reasons to use PrEP and implement PrEP and STD, kind of a higher level, so I won't be presenting any data, but just kind of what some of our motivations are. And I'm going to be talking about a statewide level program rather than in a local community. One of the strengths we have in our state is we're a statewide health department that runs all the local public health offices. So the STD clinics are part of our New Mexico Department of Health, as are our DIS, as are all of our we directly have all our contracts for HIV services, so it's really easy for us to integrate. So one of the things that we did when we were starting to roll out PrEP over the last year is really talk about what our approach is. And what happened before we did our health department rollout is what I like to call a medical approach, which is individuals who are highly motivated, well-resourced, good knowledge, good expertise, have on their own gone to their own clinician or gone to an HIV care provider and said, I want PrEP. How do I get it? I have insurance. Do I need copay assistance? Will my Medicaid cover it? Will my insurance cover it? And when we had our first PrEP summit this spring, my theory was the people in New Mexico who are going to take this medical approach are primarily going to be white, gay-identified men in their 30s and 40s who are upper middle class, have resources, and have private insurance. And we did a summit in April and asked our handful of providers who are already doing PrEP at that point, who are you seeing? Who's coming in with a medical approach? And they said, it's primarily white, gay-identified men in their 30s and 40s who are upper middle class and well-resourced. So there's nothing wrong with that. We probably have, just from that, between 25 and 40 people in our state who got on their own through this individual level approach to PrEP. Great. But we would like at the Department of Health level to really see our rates of new HIV infections go down. And to do that, we need to go to a public health approach. So the public health approach, like everything we do, is population-based, where we need to use our own strategies to identify the people who need PrEP the most and get those folks into the program. So rather than just being passive like a medical approach where one client comes in, finds a doctor on their own at a time, we need to use our own strategies to say who's most likely to get HIV, both based on our HIV surveillance data and also based on some of the risk factors. And this is where everything we do in STD really comes into play, because we know in our state we have a tremendous amount of HIV syphilis co-infections. So if somebody comes up with syphilis and doesn't have HIV yet, the odds that they're going to be a new HIV case in the next year, 2 or 3, is pretty high. There's really almost no better marker. So we have really begun since this spring doing a public health approach where we're figuring out who the clients are. We'll specifically identify and recruit, and then provide any kind of supports, referral, encouragement to get those folks to come to us. So 2 different definitions of who we want to see. We've been training since the beginning of the year. Anybody in our anybody who's an HIV and hepatitis test counselor, because anybody coming in for HIV testing who's had high-risk behaviors, primarily gay bisexual men, who test negative, they're at least in a teachable moment, readiness for prevention or PrEP. So those testing clients certainly are good referrals. So anyone at high risk who tests negative should be made aware of PrEP. But that's actually our lower tier priorities. Our higher tier priorities actually is our STD clients, because our STD clients we know for sure need PrEP. And this is the definitions of our priority population. So Gay bisexual men and other men of sex with men who've had more than one partner for unprotected anal sex in the past year, especially if they're at the bottom. MSM diagnosed with syphilis, gonorrhea at any site, so we're trying to encourage multi-site testing, or acute hep C, and we're excluding folks who've only had oral sex. And then overlapping with those would be the additional risk factors, so MSM using methamphetamines, big issue in our urban areas, MSM finding multiple partners online, particularly via the apps. We're also including transgender individuals, but only who have male partners. Somebody who's transgender who has female partners is at way lower risk. And then we are including serodiscordant couples, but it's important to note that's actually also a lower priority, because if the positive partner is in care, is viral load suppressed, unless it's a couple trying to get pregnant or a particular reason for feeling there's an extra risk, that's actually lower priority, because those are not the folks who are coming up positive. It's not the person with one partner who's known positive who are coming up as our new HIV cases. It's folks with multiple partners and ongoing risk behaviors. One of the caveats I'll put here, though, is a lot of the people who have chosen through the medical approach one-on-one to come into PrEP early are people who are negative with known positive partners. Just the fear factor alone and being able to have unprotected sex with their partner is enough reason for them individually to get into PrEP. Again, that's more of a medical approach, because that one individual might feel better being on PrEP, but that's probably not changing our rate of new infections. So really looking at those priority populations, there were two different places where STDs came up. First of all, someone who's had STD diagnosis, and second of all, just the opportunity for education in our STD clinics. And our STD clinics also are places where we have at the same site disease intervention specialists on site. So the people who really are doing the referrals are not just the folks in the clinic, but it's also our DIS team. So before we did our big rollout, we first of all wanted to make sure we had PrEP sites we could refer to. And we now have them in our two biggest cities, and then some of our smaller communities. Our third biggest city, Las Cruces, does not yet have a PrEP provider. So while we're rolling out this effort and campaign, it's a gap that if we get questions or inquiries from a city with 150,000 population, we don't have a local provider. Our website listing PrEP providers and with PrEP information is going to come online in the next month. By saying that, that means December now. We were aiming for November. And then obviously our centralized and integrated HIV, STD, and hepatitis services are going to be the best place for referrals. Our statewide HIV, STD, hepatitis staff has a clinical training once a year, and during that training in September, October, we trained and oriented all our staff to the importance of PrEP, why they're the key source of referral, how to get referrals going, when the website's going to be up, and being able to do the worm handoff. And our DIS are going to be doing more and more of that, as well as we also have infectious disease nurses in some of our regions who have an overlapping role with the DIS, but really can do a warm referral where they can have a client in front of them, call a provider, make a first appointment, and do the warm handoff. So training the statewide team is really a key part of what we're doing there. But our goal is to have 75 people on PrEP fairly soon, and eventually between 150 and 200 people. And our hope is at least half of those will be from this public health high-risk definition of folks, because if we can get at least 100 people in our state, we could probably reduce our new HIV infection rate by about a third, which would be enormous with a fairly small investment for PrEP. So thank you.
Thanks, Andrew. So we'll leave it open for a couple minutes for questions for Andrew. So, Stephen, any questions for Andrew?
I see one up there from Dan. Great question, which is, does New Mexico include public and private providers? Yes. We have some public health offices that may eventually be PrEP providers, but our strong preference is to have partner agencies doing PrEP. My personal bias is that HIV clinics are the best PrEP providers because they're the most expert. The downside there is that people who don't have HIV may or may not want to walk into an HIV clinic. There are stigma issues in our state as well. I certainly heard that from Mississippi. But our resource guide website has anybody who does free or low-cost HIV, STD, and hepatitis services, and that would apply to PrEP as well. Right now, our biggest 3 providers in our biggest city for PrEP would be 2 HIV clinics and our Planned Parenthood.
Are you using any HIV grant funds to help support this effort?
We are not using direct federal money because right now what we found with people self-referring for PrEP is very few people are put off by cost. We have had no private insurance or Medicaid denials, and we haven't even had any pre-auth demands. And so with that and the Gilead copay cards, right now cost is not the biggest barrier. We had talked about using some of our prevention funds to do an adherence support program, but the HIV clinics have a little bit of revenue from pharmacy and so on. So they've been putting up their own money and not really pushing for our resources, and I'm glad to let them do that.
Is anyone going to be following up with client treatment adherence?
That right now is at the provider level. We did, when we had our summit with all the providers that were offering PrEP back this spring, we had a big discussion of what we wanted to do to evaluate or monitor our PrEP. And the decision was, given that the state and feds were not really putting up money to get the PrEP rollout to happen other than referrals and education information, that we didn't want to create onerous barriers to doing PrEP. So we decided not to do a follow-up evaluation project at this time. So we don't have that data, and right now we're not planning to collect it.
Okay, last question. All right, last question before we move on. Is there any data being reported nationally, such as outcomes for PrEP, side effects, uptake of PrEP, number of people who drop out after 3 months, et cetera?
At this point, again, we're not doing an evaluation project or a pilot. We're just trying to broaden uptake. I think probably what we'll do is gather our providers. It's a small number. We'll probably have less than a dozen providers statewide. Gather them sometime next year and ask them to bring data to the table voluntarily, and that will have to take the place of a more formal structured evaluation. It's obviously not as good, but it's a lot cheaper.
Okay, great. Well, thank you, Andrew, and hopefully we'll have some more questions at the end. Last but not least is where we are with PrEP in Los Angeles, Ryan Murphy. So Ryan, take it away.
Yeah, good morning, or I guess good afternoon to everyone else. So LA here, we're a little different in that we're really just beginning our PrEP rollout with some of our activities that I'll be talking about being scheduled for 2016, and then where I'll do our focus is the PrEP rollout at our STD clinics, which actually just began a few weeks ago. So unfortunately, I don't have any data or slides to present, but thought I would just talk through more generally about the way we're conceptualizing our PrEP rollout here in Los Angeles. And really the way we're looking at it as a three-pronged approach. So we have provider outreach, media campaign, and referrals. And we're supporting a lot of that work through we're an integrated HIV STD program and through some CDC grants on the HIV side. And some of the activities that encompass that are, we've developed a PrEP provider database that's still fairly small. I think we have, at last count, 24, 25 PrEP providers in LA County on it. And we're planning to do some work using our syphilis surveillance to send anybody who diagnosed a syphilis case in 2015 a little PrEP survey to see if they also provide PrEP, and if so, ask if they'd be willing to be added to our provider database to grow our ability to make referrals outside of the health department. The kind of second level that we have is we have some funding to support some contracted sites. So we had sent out a request for proposals, and it's still going through the grants process here, but hoping to fund about 4 to 5 contracted sites for PrEP services specifically targeted towards MSM and transgender individuals. and we're hoping to have that up and running in 2016 as well. And then finally, what I'll talk most about is our PrEP rollout at our STD clinics. And like I said, we just had our first patients start coming through, I think it was 2 weeks ago. But to give a little background on that, just a little bit on how the STD clinic structure works in Los Angeles. As a result of our geography being such a large size and our traffic, that the clinic may be a few miles away from you, but take you an hour to get there. There's actually 14 health centers in Los Angeles County, and each of those health centers divides Monday through Friday into 2 sessions. There's actually one that has an evening session as well. And each of those sessions are dedicated to a certain type of service that we share with other departments in public health. So on certain days at certain times, it might be an immunization clinic or a TB clinic or whatever other service it is. And then we have STD clinics as at least one of those days. A couple of those clinics are most every day an STD clinic, and then there's a few that are just an STD clinic, a couple times a week. So of those 12 clinics, they're not actually operated by the Division of HIV and STD programs, but with Community Health Services, which is also in Department of Public Health. So we've worked very collaboratively with them. But of those 12 clinics, what we did is really kind of funneled down our epi and looked at where we had the highest HIV diagnoses coming out of the clinics, and have 2 that we selected that 1 day a week are going to offer or have started offering a PrEP clinic day. So how we've kind of conceptualized it is all 14 of the health centers actually, but in particular the 12 STD clinics, are kind of the patient population and providing referrals into these 2 that have a PrEP clinic day. So there's a 1 month or an initiation visit, and then a 1, 3, 6, 9, and 12-month follow-up. And at the STD clinics, when we designed our evaluation for how that rollout is going to look, we really put the focus, yes, on getting people on PrEP and maintaining them on PrEP for the year, and that's kind of our cutoff, is providing PrEP for 1 year. But our primary endpoint is actually transitioning people to primary care, either through a medication assistance program or through they have insurance and we have this set of referrals that we can provide them to. And at each PrEP clinic, there's a PrEP team, which is composed of an MD or a nurse practitioner, an STD clinic nurse, and then a DIS, who does a lot of the patient interview and the initial risk assessments. In terms of our eligibility criteria for the clinics, we're actually offering and providing PrEP to all groups, but we have different criteria within them. So for MSM or transgender women, an HIV-positive sex partner, either an anal or genital STD in the past 12 months, more than 1 partner of unknown HIV status, unprotected anal intercourse, and then we've got some other things up to the provider's discretion if they think they're a good candidate but not captured by the regular criteria. And we do have people who had previously been prescribed PEP but have continued their high-risk behavior for our MSM and transgender criteria. For heterosexual women, it's an HIV-positive partner, history of syphilis in the past 12 months, or a high suspicion that they have MSM partners. And then again, we have this kind of generic, the docs at the clinic really wanted to be able to have the flexibility to put somebody on PrEP if they were interested and they thought it would be beneficial for them. So a generic other factors at the clinician's discretion. And our intake form has a series of other risk behaviors, such as transactional sex or things like that. And then finally, our last group is drug users. And it's injection drug users sharing equipment at least once per day, somebody who's injecting cocaine or meth, or the use of and engaging in high-risk sexual behavior, or the use of stimulant drugs. And we base that off some of our local epi, looking at who were more likely to have HIV positive results coming out of our clinics. In terms of our staff training in Los Angeles County, we've really tried to take I guess kind of a tiered approach where we have a PrEP 101 training that our goal, and we're just about there, is to get all of our DIS and all of the physicians and nurses at the STD clinics to go through it, and actually even some of our local people here in our office who are the frontline people who receive phone calls from providers or patients and who are making those linkages to other services, so that everybody has a basic understanding of PrEP, who would be good candidates and knows the referrals and at least can provide that initial link. And then we have more advanced PrEP trainings specifically for the nurses and physicians at the STD clinics who are going to be prescribing PrEP, so at those two sites. Let's see here. So that's kind of I know we had on here a question about DIS, and so that's really our main use of DIS is all of our DIS will go through that training, and as they're doing their traditional STD partner services, we'll have the basic understanding of PrEP and be able to conduct some of the referrals to PrEP services. And then the DIS who are embedded within those two STD clinics that are going to offer a PrEP service day get a little more advanced training on the topic, and they actually will be conducting some of the intake interviews and assessing risk behavior and some of those things. Let's see here. I'm trying to think of what else we have on here for the clinics. So our clinics do provide PrEP at their initial visit, and they're given a 1-month supply, and then at the 1-month visit they follow up with all the lab results, and then from then on it goes to a 3-month schedule and a 3-month dosage of medication. In terms of some of our biggest barriers or challenges, I think for us, just because of our clinic structure and the fact that they're not necessarily our staff at the clinics, it was a lot of meeting and kind of getting things off the ground in terms of getting everybody to agree on the PrEP forms that we're having them send in for the evaluation and the criteria. But it's actually worked out quite well. Initially, when we started the project, we had planned on supporting the HIV medications at the clinics, because initially they had said that they didn't have the resources to really for patients that didn't have insurance and that they couldn't just refer out to help patients navigate through the medication assistance process. And then very recently, I think after just starting, they've actually had a big push on themselves to get that up and running. So we're really hopeful for that, and that can help free up some of those resources and funds that would have gone to medications to go to other supportive services. But yeah, I think that's probably our biggest challenge. We'll know a little more once we get some greater numbers and some patients cycling through the clinic in terms of who enrolls and who screens positive and chooses not to enroll. But that's really our kind of goal in LA, is this larger network of referrals that we can provide people to, either out of STD partner services or when they call in, or really any of our programs in HIV or STD. That we do, we have some other research studies or things, and pretty much everybody takes the PrEP referral list out with them. Some contracted sites, which really are focused on MSM and transgender, and that's where we have our hope of kind of getting the hardest to reach populations. That was part of the proposals they had to send to us. And then really we are envisioning the STD clinics as a provider of last resort, and really the ones who are filling in the safety net services. And our goal there is not just maintaining PrEP, but really transitioning people to primary care as quickly as possible, so that we can bring new people in and get them on PrEP and help them navigate the process and into primary care. So I know that was far less data or things than some of the others, but hopefully is as we progress with some of these activities in the future, we'll have a little more data. But at least in LA, that's our approach, is to try to move as much of it out to the private sector as possible and really focus our clinics on a provider of last resort for PrEP.
Well, thanks, Ryan. And again, we really wanted to have a wide spectrum of people. We know some people have been doing this, and other people are in the planning and implementation stage, and some people aren't even there yet. So we know people are all over the place. We're here to help people. So any questions for Ryan? And we've got a couple of housekeeping things, and we'll open it up for general questions. So while we're gathering questions, a couple quick things. These slides will be made available within the next day or two on the NPIN site, and we will also be posting a copy of this, the web and video recording within the next week or so on both the NCSD website and on the NPIN site. So you'll have a number of opportunities. If you need to get a hold of anybody, you can either email them directly or email me, and I can get a hold of people. So, again, as Bill said, NCSD is really dedicated to helping promote PrEP and doing what we can to provide technical assistance. So moving to technical assistance, just to give us an idea of what you might need, and you can check more than one of these, where do you think you need technical assistance, whether it's from NCSD or CDC or somebody else? What do you think your priorities are as far as PrEP topics? So if you could just take a second to fill this poll out. And again, you can have more than one answer. So just giving us a rough idea so we can help plan and work with CDC on figuring out where do we need to go from here. And so we'll take these results and share them and figure out our next strategies. As always, there's a number of sources for technical assistance around PrEP or any other topics related to STD prevention. First of all, your CDC program consultant. If you're not sure of your contacts, you can get a hold of Bruce Heath, and he can refer you to your consultant. And then at NCSD, we provide technical assistance as a large and important part of our portfolio. And we provide programmatic technical assistance. We have specific technical assistance related to state policy and legislation. And you can get a hold of any of Lucy or Rebecca or Stephanie. We have somebody who specializes in adolescent sexual health, Sarah Stahlberg, and we have somebody who specializes on PrEP and special populations, Stephen Hicks. So NCSD is, again, we're here to help you guys. We want to make sure that, we help you get the training and the technical assistance you need. Just to give us a little bit of feedback, if you could tell us if you thought this session was helpful, and if not, if you could send us an email on maybe some things we can do to improve the session. We'll take a second for the poll. So over half of you, almost two-thirds, thought it was helpful, so we appreciate that. And then if it wasn't helpful, again, email us and tell us, what didn't we provide, or what do you need that we're not providing, and we'll work on getting it to you. So we still have about 60 people on the call. We're going to take the phones off mute so we can have discussion. But what I'm going to ask everybody to do is put your phones on mute, and then if you're going to speak, take them off, because all it takes is one or two people talking, and it's very disruptive. So I'll give you a minute to take your phones off, to put your phones on individual mute. I'm going to unmute them from here so we'll be able to hear everything. We do have one question. Monitoring renal function is a primary barrier to full implementation of PrEP in our local health department, especially for those without coverage. Can any of our speakers address that?
So this is Phil Chan from Rhode Island. So this is absolutely a problem. What we've had to do is to make sure that people get essentially insurance through our hospital assistance program, which will cover the cost. It was interesting to hear from Dr. King in Mississippi that the Department of Health is actually covering the creatinine costs at the Department of Health level. So it sounds like there's multiple approaches that are working, but that's absolutely one of the things that needs to be covered. You know, at $2 a pop, the cost to Mississippi, it sounds like that may be something that can be low cost and implemented.
And
Okay.
this is Andrew from New Mexico. I would say, you know, one of the reasons we're really pushing to have local partners who are full-service clinics do PrEP rather than have Department of Health, public health offices do it is, first of all, they can bill insurance for a lot of these costs, and you know, we are a Medicaid expansion state, so there are resources for lab work and for everything else. The other thing is that one of the side effects, positive side effects of PrEP might be getting people into medical homes who don't have them, particularly younger gay, bisexual men and transgender folks, and particularly those of color. So if we do PrEP as a standalone service in our health department, that's still not getting people into primary care, which we can't provide. So we're only going to be doing PrEP in our third largest city out of the health department office if we really truly cannot in the next 6 months identify a local provider who can take this on. Because that's the nature of public health, is it's harder for us to do ongoing care.
Okay, another question we got is a patient able to go on and off PrEP medications, or will this cause any adverse reactions? So any of our speakers. Somebody want to take a stab at that?
Yeah, so this is Phil Chan from Rhode Island. The guidelines do say, and this is supported by pharmacokinetic data, that it takes about 7 days in a man for the tenofovir emtricitabine levels to build up. So the way that I counsel patients is I do say it takes about 7 days for the drug to build up in your system for it to be most effective. And then we don't have any good data on when to stop it, but the way that the guidelines say and what I suggest to people is basically the concept of post-exposure prophylaxis. So if you want to stop it, you should take it 28 to 30 days, a month after your last risky behaviors. So there is no harm per se in coming on and off Truvada, and certainly like our HIV positive population, there's a number of people that come on and off antiretrovirals. Really the biggest concern is that if you have periods where people are off PrEP, then you worry that they may have become HIV infected during that time, and if they don't get tested before they restart, then you may be restarting them on Truvada when they actually have HIV. So that's the biggest concern. I do counsel people that if they do go off it and want to go on again, that's perfectly fine. I do say, though, that before they do, I'd like to get an HIV test on the day that they start it. So I do encourage them to come back in. There are a number of studies that are ongoing looking at intermittent PrEP. So a common situation that comes up is a person that has, condomless sex twice a year, right? So is this person, at 2 instances of condomless sex with random partners twice a year? Is this someone that should be on PrEP every single day? It sort of makes more sense in this case for someone to be on PrEP intermittently, and so you can counsel people to use PrEP either on I guess it wouldn't be PrEP. You can counsel people to use post-exposure prophylaxis if they're the period between their risk exposures are really long. But there is no danger in and to itself of coming on and off PrEP per se.
Hi, this is Ryan in Los Angeles. I guess the other kind of implicit thing to go along with that question is, what do you do with patients who are maybe non-adherent in terms of when we're providing services directly out of the STD clinic? And we actually had a lot of back and forth with our docs at the clinic, and when we kind of initially sat down and tried to figure it out, there was, I think, a decent range of opinions. But ultimately, we kind of left that up to the provider and the doc's discretion. If the patient came in, had their first visit, got their PrEP, and then come back and report very low adherence, kind of going through the adherence counseling and trying to see what systems they could work out with them, and then from there deciding whether or not with the patient whether PrEP was a good thing to continue. But in general, I think the message that our docs have come away with was as best you can try to keep people on PrEP and work with them through any non-adherence issues before making the decision to take them off of PrEP.
Our providers in Mississippi sort of take the same approach as the physician prior, that if you're going to do intermittent use, you want to have an HIV test prior to restarting PrEP. If you expect you're going to engage in risky behaviors that you're usually not likely to, they have been recommending some people to go on it prior and then take it for a certain amount of time after.
Okay, so I'm going to, if everybody would mute their phones, I'm going to unmute them, and then if somebody wants to ask a question or make a statement, we can do that. So let me unmute the phone.
The conference has been unmuted.
So anybody have a question or want to talk about what's going on in their area? Again, if you're not talking, please mute your phone.
He has fun hair. How we did the slideshow of him.
Any questions at all?
Oh,
So a good example of why we try to keep our phones muted.
does he have kids, Shamar?
Okay, so I'm not hearing any questions or discussion. One more chance. Again, we really appreciate, first of all, big thanks to all our speakers. Great discussion. We know, again, people are all over the spectrum. Here to provide technical assistance. If you need something, you can contact Dana Crawford-Williams or myself, staff, as well as your program consultant, and then we will post these materials. So thanks, everybody, and thank you for all being on the call.
I mean, then you jumped up in it. I mean, you cannot reach after people say, well, can't do that. But look where it got you.
The conference has been muted.